Good morning. Good morning, everyone. Good morning. How are you? Good. Enjoying breakfast? Yes. Wonderful. Welcome to the second Breakfast with the Expert for this fall semester. Glad to see this nice turnout this morning. It's always a great pleasure to welcome to campus our Breakfast with the Expert guests. And boy, have we had a wonderful group of accomplished public health and healthcare leaders join us for this program over the years. But it's always much more special and near and dear to my heart when I have the opportunity, such as the one this morning, to welcome back to campus one of our graduates. So thanks, Lance, thank you for making the trip from Texas to Johnson City to be with us this morning. Lance graduated with his MPH in Health Services Administration in 2009. He was one of our most focused students. He knew from the time he started the program that he wanted a career in healthcare administration. So during his first summer, after completing just 2 semesters of coursework, he sought and secured an internship with Houston Valley Medical Center in Kingsport. He performed so well during that summer that the hospital extended his internship for 2 additional semesters and with pay. So by the time he graduated in 2009, he had a 12-month internship under his belt. He immediately entered the field of healthcare management, initially in medical group practice management, and then quickly transitioned to hospital management. Although his career is only 6 years long, he has had a very productive and rich experiences that took him overseas to run hospitals in Egypt and in Saudi Arabia, and then back to Texas. He's practiced in urban areas and rural areas, and he's currently the hospital administrator and rural market leader for Christus Jasper Memorial Hospital in Jasper, Texas, where he is responsible not only for the hospital operations, but also for 3 rural health clinics that are part of the hospital system. So again, thank you, Lance, for waking up at 3 a.m. yesterday morning, driving 2 hours to the Houston airport to get on a flight to Charlotte and then another flight to Johnson City to share with us some of your experiences in rural healthcare management. We're looking forward. Thank you.
Thank you. Good morning. It's good to be back in Johnson City and back in the place where I've spent the most time in one location in my 10 years of marriage. We lived here for 4 years, and we've lived on 4 continents and 4 countries and 10 states. So Johnson City is near and dear to my heart. So today I want to talk about some of my experiences I've had and talk about some rural markets, some rural communities, and how we can expand healthcare, given the challenges that we have now and given the opportunities we have with some of the resources we've been given. Accountable care is here, Obamacare, however you want to call it, is here. It provides challenges, it provides opportunities, but the reality is we have to use it. And so I'll talk about that. If you have any questions or comments or anything throughout the presentation, just raise your hand, feel free to stop me, shout it out. I just want to make sure that I give you guys what you all are looking for. So one of the challenges that I'll talk about briefly is in healthcare nowadays, you have to wear multiple hats. There's no more, this is my job description, this is what I do. And so my assistant is also our employee health nurse and our risk manager, and that is why my slides are really not that fancy. So let's just get to it. So just right off the bat, there is a a disease that's killing rural hospitals, and it's hurting communities. In fact, a third of rural hospitals operate at a deficit. So how does a hospital operate at a deficit? Well, they usually have cash reserves. So back in fee-for-service, it was easier to make money, and so they have these big stockpiles. And that's operating revenue. So there's other ways to get revenue. Different government programs, UPO programs, disproportionate share hospitals. So if your hospital provides a disproportionate share of uncompensated care, you can get some federal dollars for that. So that kind of makes up for it. But the reality is it's very difficult to operate in a rural market now. A lot of people go to bigger tertiary care hospitals for their care. They just associate a bigger hospital with better care, better doctors. And so you see a lot of people leaving those hospitals or leaving those areas to get their care. And so what that does is it drives down the ability of that hospital to make money. And there's several reasons for that, one of which is a lack of physician specialties. So in my market right now, I've got an orthopedic surgeon who invented the wheel. I've got a urologist who helped him invent the wheel. They're like 90 years old. They're at the end of their life. And there's just not a whole lot of confidence in them in our community. We got a general surgeon that's a young guy, so that helps out. But when people come to the hospital and they're in the ED and they get a consult and the urologist comes and he has a walker, they want to go. So, and it's true. I'm not joking. He really does. And so they want to go, and I would too. And they want to go to other places. The other thing is we don't have some of the diagnostic equipment that these big hospitals can afford, or some of the other equipment. Okay, if I were right now, if I needed a prostatectomy, I would go get it done with a robot, okay? My hospital can't afford a robot. It's just far too expensive. We would never get an ROI, a return on our investment, if we bought a robot right now. And so a lot of people are saying, well, I'm going to go to a market that has these things. And again, if we may be able to do that procedure laparoscopically or open surgery, but people are looking at these new technologies, and so they're leaving. And so all that stuff leads to declining occupancy rates. Okay, so the fewer days that you have patients in your hospital, the less money you can make, and so that drives it down. It's going down 5% from 2006 to 2013. 5% is a lot. Okay. So lower case mix index. Case mix index means how sick your patients are. So if you have a high case mix index, your DRGs for Medicare are going to be higher, and that's what they pay on diagnostic related groups. And so the higher your case mix index is, the more money you're going to get for that patient. Okay, so there's different ways to combat that. So one of the things that we did just recently in January, we got a hospitalist group, and I'll talk about more how that goes in here, but in later slides. But we got a hospitalist group, and so they can take on more than just a primary care physician, and so we can keep a little bit sicker patients. And so we saw in this last year a pretty big bump in our case mix index, which helps our financial bottom line. Also, lower surgical acuity. So, we can't do total hips at our hospital, and so those will have to leave. If we could do total hips, those pay very well, and it would help us out significantly, but we just don't have the skill set at our hospital to do that. Lack of capital. That's another thing that is hurting rural hospitals, okay? So there's different ways to acquire capital. You can do operating leases, you can do capital leases, you can outright buy it. But the truth of the matter is it's just more and more expensive to acquire new equipment, new technology, and rural hospitals are just, with declining reimbursements, declining services being produced at their hospital, and that sort of thing. It's just hard to get new stuff. High uninsurance rates. So out in rural areas, there's more people without insurance, and so that's not a unique problem. But as commercial payers fall in line with the governmental payers and reimbursements go down, it's not making up that gap. Okay, because it used to be whatever you would lose on uninsured patients, you would make, or governmental insurances, you would make up on the commercial side. But everything is shrinking, and so that gap is getting shorter and shorter. Another problem is, I took a Zyrtec, and so I'm totally dried out, so I'm going to drink a lot of water during this. Physician burnout. Okay, so we have a limited amount of physicians to do a lot of roles. And so imagine this, you're a primary care physician, and you see full load of patients, and then you have to go see your nursing home patients after that, and then you're on call for your group, and then you have to wake up the next morning and go to a medical executive committee because there's only 3 members of that medical executive committee, and so you have to be on that committee, and then you also have to go to quality the next afternoon. And there's a lot of things that just make you burn out. And so, those are things you have to come up with creative ways to combat. So you might get like locum tenens doctors to come in, but that's very, very expensive. You may have to pay them to compensate for their burnout, which works for a time, to take call. And so there's different ways you can work around that, but again, it's a big problem, and it exists in pretty much every rural area. And even a lot of urban areas, doctors are just getting burnt out. They've got tons and tons and tons of paperwork. So you might see 25 patients or 30 patients in a primary care practice, but it takes you 12 hours now. You used to be able to see 50, and it would take you that amount of time. So you're getting paid less because there's more work involved every time you see a patient. You've got to fill out tons of paperwork, and it's just more complicated. The other thing that kills people is operational inefficiencies. And what I mean by that is there's so much work that has to be done, and if you are a standalone hospital, you've got to have a resource to do that. Okay, so you might have to have a CFO or a controller. You'll have to have an IT person. You'll have to have a human resources person, and so personnel starts to get very, 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 very expensive. And it may not be where they're totally used properly. So they may actually work 20 or 30 hours a week, but we pay them for 40. Otherwise, we wouldn't have them. And so that's very inefficient. Clinical process development, that's another thing. That's very complicated, and it's required. We've got to use EMRs. We've got to report a lot of data as we start to go into pay for performance and track all these quality measures. It takes a whole team of people to do this. And again, that's very expensive, and the more that we can streamline that, the better. And then again, technology. Technology is so expensive. So if you go out and get a big EMR platform to put at your hospital, it could be millions of dollars. And that goes back into the capital, and it goes into the personnel efficiencies. And also, you want to make sure that your clinical pathways and your protocols are kind of consistent with a national level. And so if you can kind of piggyback on somebody else's, it makes it easier. If you're developing your own, it just causes a few problems. So I want to show this slide. So I talked about reimbursements going down. So there's a lot of things that play into this. So over here you have over 250 beds and then under 250 beds. So most rural hospitals are in the under 250 bed range. So that's inpatient. Here's surgical. So there's a pretty big gap. That's almost $10,000 per surgical case less than what you would get at a bigger hospital. And again, that's because you've got a higher case mix index over here and sicker patients and more complicated procedures and that sort of thing. So if you look at just a number of procedures done at the hospitals, it's not apples to apples. You could do 10 procedures at Johnson City Medical Center or 10 procedures at Unicoi County, and you'll get 2 different sets of numbers off of that. And so you just have to work around that. But that's a pretty good slide to show you. It's tough to run a rural hospital. That slide did not work out the way I hoped. It says 16 hospitals closed in 2014, 16 rural hospitals, and 283 are on the chopping block. 283 hospitals are in the danger zone and are kind of on the brink of extinction. So that's pretty daunting because when a hospital leaves a community, that leaves a certain portion of those people who won't get care. Because right now they're going to that hospital because it's close to their house, but they may not be able to afford the gas to get down to a bigger hospital, to a different market. They may be intimidated. They may not know what to do. They don't have that resource. Their cousin doesn't work at the local hospital. So, they can't call them and say, what do I do? And so it's hard to navigate. And so these hospitals are really, really, really important to these communities. Okay, so some solutions. I'm sure there's more buckets, but I put it into 3 buckets. You can do an affiliation with a bigger hospital. You can do an acquisition or a merger, or you can stay independent and get creative and try to figure it out. So an affiliation, I could go and I could say, if I'm a small hospital, I could go to Johnson City Medical Center and say, listen, I'm not realizing all my revenue. I've got really long AR. I've got stuff that's not billed because it's not been coded. My coder was sick last week. and they haven't done anything. So you might go there and say, hey, can I piggyback on your revenue cycle? Can I send all of my documentation to you? You bill it and then pay me back a portion of it, 98, 99% of it. And just use that. GPO access, Group Purchasing Organization, okay? So if I'm a standalone hospital and I go buy a box of Band-Aids, I may pay $12 for them. Johnson City Medical Center may get them for 30 cents. Just because when you buy a billion Band-Aids, it's cheaper than if you buy 12 Band-Aids. So having access to that is very, very crucial. So the biggest expense at my hospital is personnel, is salaries and wages. My second biggest expense is supplies. And so if you can get into a group purchasing organization, that can really save you a lot of money. Transfer agreements, where do I send my patients? Excuse me. And when I send them somewhere, do they send them back? So if you have a transfer agreement, I can say, I'm going to have this patient, as soon as they get to X point, I'm going to send them to you. Once you get them okay, send them back here. Or if there's follow-up tests, make sure you send those ancillary tests back to my hospital so I can get that revenue. If you don't have those agreements, sometimes, like let's say I'm out in Utica and I send it to Johnson City Medical Center, well, they may say, hey, come back here and follow up and get all these tests done. Well, that's just revenue that I lost. And then capital acquisition. There's a lot of ways that you can partner with bigger organizations, and they'll help you out with capital. When I moved to Lufkin a few years ago, Texas, we were a 150-bed hospital, and we had a lot of our OB patients, our women, going down to Houston for maternal fetal medicine specialists. I can't say that fast. So the problem was there's these women, a lot of them were Medicaid, and a lot of them didn't have the money to go down there, and so they were missing out on all this maternal care. And so we partnered with them, and we said, listen, we will have all of our patients go to your physicians if you get us this telemedicine equipment. And they said, yeah, sure, of course. And so anybody that was real high risk would go deliver down there. If there was a baby that delivered that was bad, they would go to the NICU down there. And so it was a good moneymaker for them. But they spent about $100,000 in some ultrasound equipment and some telemedicine equipment. So those patients would come to our hospital. In real time, one of the techs at our hospital would do the ultrasound. It would show up on a screen, and the physician would read that. And it was great. So we got to get that technical portion of that, and we made money doing that. Where otherwise we would have lost it, and really it was a problem for the patient because they just wouldn't have got that done. And so there's a lot of things that could be treated during the course of that pregnancy that were going missed because they weren't doing that. But it was also good for that hospital that we partnered with. They got those NICU babies make a lot of money for a hospital, and those high-risk pregnancies make a lot of money. So it was good for them. So there's a lot of associations like that you can do and go out and have people buy equipment for you if you promise to send your patients to them. Acquisition and merger. So this is getting it's heating up. So in 2010 there were 74, 2012 89, and then 95 last year. So that's another way. So that's going to increase. That's going to continue to increase. Those 283 hospitals that are out there, kind of on the chopping block, they're going to have to make a decision. And sometimes it's easier to go with an acquisition or a merger. They come in, take up your whole shop, they do everything, and kind of expand their footprint. And we'll talk about that a little bit. Or you can stay independent. But if you stay independent, you're going to have to do a lot of stuff, and it's really difficult. You have to have pay for performance. You have to capture all that data. You can't just say we're going to continue to operate like we were and expect to survive. You really need to cut out the waste. So if you've got an HR person that really only does 30 hours of work per week, and you're paying them for 40, you're going to have to cut that 10 hours out. You're going to have to cut out all the inefficiencies, all of the waste, all of the money that you're spending out that's not getting a return. And you're going to have to develop new and profitable services, which is very difficult, again, because of access to capital, access to specialized physicians, and that sort of thing. Okay, so what does a partnership look like? And what does each entity get in this exchange? Okay, so these are some slides that I got from the advisory board. They're a healthcare think tank. And they are awesome. If you ever get a chance to go to one of their meetings, they are awesome. They're all like nerd PhDs that have really good personalities and have really engaging meetings. And so they're a lot of fun, but they are really smart and they do really good work. And so at Christus, we are, I don't know, sponsor or whatever, or we spend a lot of money with them. And so they let us use all their slides. So I just copy and pasted it instead of coming up with my own. But again, we talked about some of this stuff, capital access and operational scale. So at our hospital, because we got acquired by Christus Health, I've got 1 day a week, I've got a person from finance come up. But she goes to 2 other hospitals. And so we get, I guess, some economies of scale with her. Clinical support. So we have a chief medical officer at our big hospital in our region, and then we've got a chief medical officer for the whole system. And so they're really pushing that clinical support and providing that for all the small hospitals that we couldn't otherwise afford. We just could not afford somebody to come in and do all that work for us. So we get to piggyback on some of their clinical stuff. And then branding. Branding is really important, okay? So we've got a couple of strong brands around here, Mountain States and Wilmot. Down in Texas, some of the big names are like Memorial Hermann and Houston Methodist, and that sort of thing. So as people start looking and saying, we really want to keep this hospital here, and we want to give our patients, some confidence that if they came here, they're going to get the same care as if they drove to Houston. So you can kind of piggyback on some of that branding. And that is a really effective way to kind of promote your hospital. You'll see this all over the place. There's a lot of affiliations with like the Cleveland Clinic and the Mayo Clinic. And I don't know how much of Mayo Clinic or Cleveland Clinic really trickled down to some of the other places, but the brand certainly does. I mean, there's billboards and it's all over the place. And so maybe it's in some ways a false sense of confidence, but nonetheless, it drives business. So why would you acquire somebody? What's the benefit for you? Well, it's market capture. Okay, so if you go into a new market, and this hospital is now affiliated with me, I've just expanded my net, and I can not direct all of those patients, but I can redirect a lot of those patients. Where if I'm a small hospital and all my patients go left, and I get acquired by south, then some of my patients will start going south because there's some continuity of care. They may see the same physicians at my hospital and the hospital to the south. Okay. Low-cost care sites. So instead of me, a big hospital system, going out and buying property and building a new hospital, I've already got one out there, and it doesn't cost me as much in capital. It's very expensive to build a new hospital and put new equipment in, obviously. It's much more reasonable to go out and get an existing hospital and maybe put some new capital into that and do some new beds or some new equipment or something like that. But you don't have to go in and do the whole house on day one. And then, like I said, that care continuum. So if somebody comes to my hospital today and they get admitted to the hospital and they're seeing a hospitalist there, he comes every day and rounds on them, and then they go south and they've got to get transferred to a higher level of care, they're going to get transferred to somebody in their group. So they already know all their background, all their clinical information, and they may end up seeing the same person. So there's some continuity of care. They've got our access to our PACS system. PACS is a picture archiving and communication system. So if a physician does an MRI at our hospital and they're looking at it on the screen, that can just be immediately shipped down and viewed simultaneously on another screen. So all that stuff just flows through, and you don't have to rerun a bunch of tests, which is very expensive. People don't like getting poked, that sort of thing. So what's the goal? The goal is to make it more financially viable for both parties. You get more market share for the purchaser, and then you get to operate. You get to continue to operate. So there's some clinical advantages. You can use some best practices, some evidence-based medicine that goes across the entire system. And there's that continuum advantage where patients don't have to, even though they're leaving the facility and the location, they don't have to leave the system. So one of the big questions is, do I go with somebody like an HCA or a community health systems that's a big national provider that has 200 plus hospitals, or do I go with a Mountain States Health Alliance or a Wellmont that's kind of local? And so there's some pretty big differences. One of the differences that I want to talk about really is this sharing physician talent. So if you go with HCA or CHS, you don't share physicians between facilities. But in my facility, there's a lot of physicians that will come up and we get to share them. And so being part of CHRISTUS is really beneficial to me because I get boots on the ground, people there to help me out. Being a national provider has its benefits too. So a lot of times they have better GPOs because they own the GPOs a lot of the times. And information sharing is really big. So they have these big, huge platforms, and they get so much information. They can accumulate so many statistics that it helps out there. The other thing that I should point out is as the health insurance system is changing, there's going to be more narrow networks. Meaning, if I'm Eastman, I may say I'm going to kind of squeeze my network and just go to Wellmark or just go to Mountain States. And so if you are part of that partnership, then you get to go into their health networks and that sort of thing. And so you can kind of leverage the market and you can get better rates. Where if you're just negotiating by yourself, it's difficult to negotiate. So what really works for you? I guess the question from the outset is, what kind of autonomy do you want to have? What kind of control do you want to have? If you want to have total control, you just want to practice in a network, or just do some best practice collaboration. Hey, let's share, what you do when you've got heart failure. Let's share what you do when you have AMI. What are some of the things that you're doing that we can implement here? And then it just continues to go down. You can have a joint venture. You can have a management agreement. And then the two big ones are lease. So if, like, the hospital I'm at is owned by a hospital district, which is a governmental agency in Texas, and we are outright leased. And so CHRISTUS, they employ all of the employees. They buy all the equipment, everything. And then merger or acquisition is where there would actually be a transaction and a purchase. And then, of course, at that point, that system would own the hospital, and whatever they say goes. So, these are things that you have to work through. Depending on what your governing board looks like, will have a big influence on those decisions. So we talked about, the environment is what it is, and the ACA is here. And so we've got to leverage that. And so one of the goals of ACA is to increase access to health insurance. Has anybody signed up for a personal policy?
The marketplace.
Yeah.
Yeah.
Gone after the marketplace. Is it super, super easy? Yeah. Okay. And you guys are, college educated, pretty computer literate, I would assume. And it's still difficult to navigate. Can you take somebody that reads at like a 6th grade level that dropped out of school in 4th grade or 6th grade and then have them go and sign up? Like 80% of people don't know what a deductible is. So when you're going and making these decisions, how do you know what program to sign up for? How do you even know that you're supposed to sign up? Isn't the government just going to sign me up if they're mandating this? Aren't they just going to assign me to insurance product? So one of the things we do is we have these certified assistant counselors, and so they come in and we'll set up at a couple locations computers where people will come in, we'll sit down with them and help them navigate and go through and make sure that they're insured. And we promote that big time and send out stuff, on the radio and the newspapers and everything, and invite these people to come in and we'll help them. And these people are really well trained. They can really navigate through the systems and match these people up with products that work for them. One of the problems is people get the cheapest premiums, and then they can't afford the deductible, and they can't get access until they pay their deductible. And so those people will help them sit down and say, listen, if you pay a little bit more, then you'll have a copay at the doctor, and it's $25 rather than the entire cost of that visit. So those are just really helpful things, and you really need to be an active participant in getting people signed up for that stuff and helping them navigate that. That way, when they come to you and they say, oh, well, I've got insurance, but I have this huge deductible and I can't meet that, then you're in a self-pay type situation. So that doesn't help out at the hospital. And then Medicaid expansion. So depending on what state you live in, if you live in Tennessee or if you live in Texas, we didn't expand Medicaid in our brilliance. And And so there's other things that you need to look at. So we have what's called the 1115 waiver, and there's different ways that you can kind of access some federal dollars. We did a program at my hospital, so we have an IGT, an intergovernmental transfer agency, and so we can put up dollars and they will be matched at a certain ratio. So we put up $250,000 and the government matched it with federal funds of $600,000, and so that meant a lot to our bottom line. And so there's different programs out there like that, UPL, upper payment limit programs, that you can go out and get in lieu of the Medicaid expansion. And it looks like Florida, they also did not expand Medicaid, and it looks like they were going to expire their 1115 waiver. So we'll kind of wait and see what happens there. I think they've sued, and it's a mess. But anyways, regardless of what happens, you're gonna have to roll with the punches and just deal with it. And so the other goal of ACA is from this acute care model to accountable care. Okay, so it's not okay anymore for people to show up to our hospital, we treat them, and then send them on their way. Okay, it's really not okay for people to show up to our ER that have a nosebleed and for us to put them in the ED and charge them a whole bunch of money when we could redirect them to the appropriate setting. And so what we've done at our hospital, we've got a community health worker, and so she screens all the patients that come into the ED that are either uninsured or underinsured. And so, in going and talking to them, if they've got medically screened where it's not an emergency type situation, she'll go in and say, do you have a primary care provider? Have you been over to our community health center? And that sort of thing. And make sure that they're getting that right care in that right environment. Otherwise, it's very, very expensive. And so if I have a nosebleed or some really insignificant injury or sickness, and I can go to a federally qualified health center, it's going to be a whole lot cheaper than paying a hospital bill and a ER physician bill, which I may never pay. So it's in our best interest as well. So our bad debt doesn't continue to go up. Like I said, it's not okay for us to treat somebody and kick them out. So this person will also go with them and say, hey, listen, do you have a primary care physician that you can follow up with so that you can make sure that the medication that you've been given here is working properly? Or if you have other questions, you can get this stuff. So they'll make them follow-up appointments. If they need to go to a specialist, they'll make them specialist appointments, and they'll follow up and make sure that they went to those appointments. And if they didn't, we'll try to figure out what happened, what prevented them. Was it transportation? Can we help out with transportation if you're on Medicaid? A lot of times we can get transportation for you, but what is stopping you from getting that care and preventing you from coming back to our ED? Okay, so that dialogue happens, and good things happen from there. Okay, so one of the other things we have to do is expand primary care, which is difficult in a rural area because it's hard to attract physicians. So you can do a couple things, and rural health clinics are one, and the FQHCs are another. So there's some certain requirements. You've got to be in a rural area, non-urbanized area, and you've got to have a nurse practitioner, and they've got to work at least 50% of the time in your clinic. In a rural health clinic, you have to have certain labs, and you have to have certain medications to provide care in emergency situations. It's got to be a little bit more than just your normal doctor's office. And all those things got to be there, but you get paid a little bit more too. So it's a lot better financially to have a rural health clinic for primary care where they do an all-inclusive rate. And I think it's about 125% of the Medicare rate, which is good. And then there's the FQHCs, and they've got a little bit different model. So they either need to be in underserved areas or underserved populations. There can be a definition like inside of Chicago, as long as there's a group of folks that meet certain qualifications, you can operate in an urban area, but it's just got to be an underserved population. But so they're grant funded. I can't remember what grant it is. So they either need to be grant funded, or they need to look just like they would if they were grant funded, or they need to be in a tribal area. And they offer sliding fee or sliding scale fee schedules. So if you can't afford a $50 copay, they're going to slide that down for you and get it to somewhere that it's affordable. That way, people are getting the care they need. Otherwise, people go with untreated diabetes, people go with untreated heart disease, and they show up in my emergency room, they can't pay, they still can't pay, and now it's a whole lot more expensive to treat them. And they have to do a few things with diabetic education and some other things. Oh, that worked. Okay. Okay, so the next thing is telemedicine. One of the ways you can really increase access to providers is through technology. And telemedicine is here, and it's coming, and it's evolving. More payers are getting on board and that sort of thing. And this is a pretty complicated slide. I won't really go into it all that much. But the thing that is really helpful in my community is, or will be, is the education piece. So you can get a board-certified neurologist on the phone, on the video, meeting with a patient, okay? But there's always a physician in there as well in those consultations. And so that physician is learning a lot about neurology as well. And so if he sees that particular problem, he may know, and next time it's not an emergency type situation, he'll know what to do because he wasn't trained in neurology. And so it's learning for both, but it really gives people access to really good physicians that just could never make it in a small market, boots on the ground. But there's a ton of different things that you can do, a ton of different ways that you can leverage telemedicine. There's mobile apps, there's remote monitoring devices. So what we're doing in our hospital, I really wanted to do some sort of telemedicine platform. And so there's a lot of different options, a lot of different opportunities. And so what I looked at was, because it's fairly expensive to get started, so what I looked at is what am I going to get the biggest bang for my buck for? And how can I pay for this as quickly as possible so that I could do other things? So we looked at teleneurology. We transferred out 143 patients from our hospital to other hospitals with neurology, stroke-like symptoms. So now we can do, and that's bad for patients because time is very, very important in those sort of situations. So if we can administer TPA, which is the clot-busting drug, that's really good for us. It's like $8,000 every time we administer that. So that's very good. And we won't get 143 of those, but if we get 20 of those, then you can do the math, and that's pretty good, and it pays for itself in a year. But with that, you get kind of a really robust cart. And so that cart can then be used for teledermatology or telecardiology and those sort of things. And then you can start getting economies of scale with your cart. And so that's what we've done. And there's a couple different ways, just like with a local provider or a national provider. Who do you partner with when you're gonna do telemedicine? So we went with somebody who's bigger, who has a kind of a bigger net. And the reason we did that is we would have more autonomy over where we sent those patients. If you go with like a bigger local group, they want all of that stuff to go towards them, of course. But we wanted it to go to our bigger hospital. And so we went with a national group, and it hopefully will start in about the next 60 days, and then we'll continue to add there. But that just because there's no possible way in Jasper, Texas that a neurologist is going to move there that we would want. I mean, maybe you got fired from 4 other hospitals and you can't find another job, but we don't want that guy. We want somebody who's in good standing with, the American Board of Neurology and that sort of thing. So in order for us to get them there, we've got to get a computer monitor. It's getting bigger. It's not just Jasper, Texas. It's everywhere. And you can see the trend in 2020. It's $58 billion of market growth potential. So that's significant. That means it's going to grow, and then keep growing. It's way cheaper for us to do that than to pay for a guy to come in, locum tenens, and provide neurology coverage. Okay, so you might pay somebody $2,500 a day to come up there as a neurologist. Or you could pay a per diem rate of $385 and have them available through telemedicine. And so just financially, it's so much cheaper to do this. But you can do a lot of things. And one of the things that's nice about having somebody who is board certified and you know their credentials is it's reliable. You know that they're going to be used evidence-based medicine. They're going to be used national standards of care and that sort of thing. And so your patients are going to be taken really good care of. There's a lot of things that can be done, especially with chronic diseases. You don't really need to go see a physician. It may be where you get on a monitor and they ask, how how's this therapy going? Is it affecting anything? You can have that dialogue. It's a short dialogue, but you don't have to drive 60 miles into town to do that. You can do it from wherever, as long as you can access that technology. The other thing that we've been thinking about doing is putting access points throughout the community, so they don't actually have to come to the hospital even with some of these services. So some of the clinical benefits is there's reduced ED visits. Okay. Now that's kind of a double-edged sword. I mean, I want my ED to be busy. That's the front door of the hospital. That's how I get a lot of my admissions. So I want people to come to my ED. However, I want the right people to come to my ED. I don't want people who really don't need to be in the emergency department and don't have insurance to come there because it's very expensive. That just increases the amount of staff that I have to have, and that's very, very expensive. It increases the amount of supplies that I use, and again, that's very, very expensive. And also improved coordination of care. These people can coordinate. We can schedule them out, follow visits in the appropriate place with the appropriate person, and reduce readmissions. Readmissions is another one of those things. With pay for performance, we've got to reduce these things. We've got to get people well and keep them well, not just acutely treat them and send them out. When they come back, it's very expensive, and it's just not good medicine. Okay. So like I said, more insurance companies are starting to get on board with this, but it's a little bit chaotic. So there's 21 states in DC that mandated insurance companies cover this, but there's no continuity of requirement. And so we've really got to work through some of these things. Some of the commercial insurances are joining on this, and so we'll see this. Again, as there's more demand, the insurance companies are going to have to react to this and provide their patients with the ability to get these services without an additional cost to them. So in a rural hospital, you really have to get out and you have to start and you have to make connections with people. You have to get out there and make relationships with folks. So our FQHC is grant funded, and their grant is based on the number of patients they see. And so they are really incentivized to see more patients. We are incentivized to keep people out of our ED that don't need to be there. And so if they truly can't pay, we will we'll pay like a $50 copay for a patient to go from our ED to the FQHC and get the care there. That way they're not totally out of the cost, but it's much cheaper for me to pay $50 to send somebody over there to give them to admit them to the hospital, or well, I guess they wouldn't be needed to admit to the hospital, but just to provide that service there. So you have to have those relationships there, and they're happy to do that. They're happy to take those patients, and we're happy to give them. Local primary care providers, you really need to go in and talk to these folks and figure out how can the hospital help you stay here in the area. What are ways that we can work together? So I did this not too long ago, and I'll tie these two together. I went and talked to a physician. I said, what can I do to help you? And he said, get some medical students here, some residents going through here. It eases my burden, but it also helps with recruitment. Oftentimes they stay if they really like the area. So we went up to University of North Texas. They had a residency fair, and we talked to some people. And we tried to set up a residency program, and I think we've about got that completed. But that was a huge help to him. I don't see it as a huge help to him, but he does. And so if we can help him, that'll keep him happy and keep him in the area. Food banks, a lot of times these people come in and, they don't have anything. They're totally destitute. And so there's ways that you can help them out too. They give us goodwill, and that's just, I think, the right thing to do. Prescription assistance, there's a lot of prescription assistance programs out there. We had a thing called Jasper Share, and so people would donate money, and a lot of that money would go towards prescription assistance. So going out and finding all those resources, and just any other charitable organization that would be willing to help out, to give money, because all the money we get is of course, well received. And employee wellness. Okay, so we have some employers that are self-insured, and so they have a lot of money going into the health and wellness of their employees. And so if you can go and partner with them and show them how you can reduce their costs by getting their patients or their employees into the healthcare system at an earlier time, and you can help manage some of these chronic diseases, that their output every year financially will start to decrease. It may increase at first, but it will decrease with some of the best practices that we have. And so we just started something with the Jasper Independent School District, and we did a biometric screening and got some baselines of folks. And so then we could intervene and say, listen, you are borderline type 2 diabetic, and here are some of the therapies that you need to get yourself in line. So if we can fix their diet and their exercise and help them know what some of the consequences are if they don't fix that, then maybe we can keep them off insulin. Maybe we can reduce the number of ED visits they have. And that's a huge save for that company. So if there's different ways we can do that, there's a lot of examples of how you can decrease the costs and also get them plugged into a primary care provider. That way, if they've got the flu or something, they can call and get a primary care provider rather than going to the emergency room or going to a urgent care shop, which is, of course, more expensive than just going to a primary care physician. Okay, 340B. 340B is a prescription drug program, and the government required all these drug manufacturers to provide discounts to certain folks. Okay, and you've got to meet some certain requirements. You've got to be not for profit, and you've got to provide and get some FQHC. Again, is one of those people. And these are outpatient drugs only. So people who come to our emergency room or are admitted in observation, those are the people that can access these drugs. And there's a huge discount. And it's the difference between somebody being able to afford their drugs and somebody not to be able to afford these drugs. And so it really takes a big burden off of us. So if somebody comes into where you are and we can provide them with much cheaper drugs, that's money that we save that we can reinvest. And there's a requirement to participate in this program, and you have to show what you're doing with those savings. Are you providing uncompensated care? Are you getting new services, or whatever it is? But it's really a significant amount of money to us. We also partner with like Walgreens, so they may have access to these 340B drugs. It's bill to, ship to, so they may bill us for the drugs but ship them to Walmart or Walgreens, and then the patient would go and access it there, and then Walmart or Walgreens would send us the difference. And so they don't just have to be at our hospital, they can go out to some of these contract pharmacies, and we still get that financial benefit. And so there, the burden is, of course, on the insurers. But if somebody is uninsured and doesn't have prescription coverage, and they go to Walmart, we could give them a voucher and say, listen, give this guy 50% off this drug, and you can access it. There's no cookie cutter way to go out and expand markets. There's no cookie cutter way to make your hospital financially viable. You really have to build relationships and see what's out there. There's other people that have done certain things. You're not going to have the best ideas. So going out and talking and collaborating and those sort of things are really going to help you understand what the problems are and then give you opportunities to come up with creative ways to fix them. Collaborating, again, if it's with a hospital system, if it's with a physician or a group of physicians, there's a lot of ways to collaborate to figure out how to solve for problems that physicians are having with their patients getting access. It may be that they can't get in scheduling wise or something like that, but just going out and talking to people. And community goodwill. So that goes a long ways. If the hospital gives back to the community is more likely to access services at that hospital. And so going out there and repairing relationships that may not have, or that may have soured for one reason or another, is very important in supporting the local folks. You really have to get creative with recruitment. And that goes with physicians and specialized staff, nurses. It's difficult to recruit to rural areas, some of those specialized folks. But I think the takeaway is passion. If you really have a passion, you can't do this for money. You can't say, I just want to make this hospital money, or I just want to personally make money. That's not going to get it done. You really have to be passionate about the people you serve, the area you serve. And that's where most of your creativity is going to come. If you were trying to create a way for your for your mother to access care, you'd be a lot more creative than if it was just some random person that you didn't care about. And so if you get emotionally invested in these communities, it's going to go a whole lot further, and you're going to be a whole lot more successful. All right. Is there any questions?
That was a lot.
Yes, from the expansion of the Affordable Care Act, have you began to start seeing monetary benefits from it?
Well, so we did not expand Medicaid
Okay.
in Texas, and so that would have been one of the big benefits for us. And so we saw a financial benefit because of the waiver program and the federal dollars that we were able to access because of that. Hopefully Texas jumps on board and expands Medicaid. Just because so many people in our area cannot afford the insurance products that are in the marketplace, and so we haven't seen the expansion of coverage yet.
Okay.
And that's something I've always tried to reconcile, because I know that Medicaid is a huge financial loser for the hospital, but yet how is it that Medicaid expansion would help it just because they would have something is better than nothing? Is that basically?
Yeah, something is better than nothing, for one. And then number two, a lot of rural hospitals can get cost-based reimbursement for Medicaid. So for me, Medicaid is good.
What does that mean, cost-based reimbursement?
So whatever it costs me to provide that care, there's no gap in the margin. So I'm not going to make money on Medicaid, but I'll get whatever I spend.
Who funds that? Who funds the cost-based reimbursement?
Taxpayers.
But it doesn't work that way in an urban setting, just for rural hospitals.
Yeah, for rural hospitals. But again, so if you take a person that's getting uncompensated care and then move them to Medicaid, something is better than nothing. A lot better than nothing. Go ahead.
Well, I had a comment and then a question. My comment is that being a nerdy PhD and being cool at the same time are not mutually exclusive characters.
No, not at all. Not at all.
I just want to make sure that we clarify that. I was going to ask you about
There's
Medicaid
living
expansion.
proof here.
I was going to ask you about the Medicaid expansion, because you were kind of talking about that, but I also think that cuts in disproportionate share and some other counterbalances to outweigh non-expansion are kind of an issue there. One thing that I noticed, and I'm sure that Dr. Beatty would have this question as well, your list of partners that you interact with did not really include local health departments. Could you expand on to what degree you all interact with your local health department?
Yeah. So one of our physicians that's employed part-time in one of our clinics also works at the health department. And we take, if there's any referrals from the health department, we take them, whether they can pay or not. So, I mean, that's, I could have included a lot of things on that slide, one of which is local health departments. But we provided a lot of uncompensated care.
The slide you mentioned, the larger bed hospitals and smaller bed, and there's like a $10,000 difference. Is there ever a time that it would be more beneficial to turn away or not take any business?
Financially, yeah, there's some losers on some certain things. Not a whole lot. But I mean, if we can do the surgery at the hospital, we generally do it.
So as far as like the telemedicine that you're talking about, like does this cost like what it costs the hospital to like have to like buy into like a national level to have to be able to like?
So there's two costs for us. One is the actual equipment, and then two is the provider piece. So the equipment's about $25,000 or $30,000, and then we pay per diem rate for somebody to be on call. So when we call them, they answer the phone, and I think it was like $300 a day, and then we get a bill for the physician portion as well.
So it technically it wouldn't necessarily be bad for the hospital. It'd be better.
Oh yeah, it's definitely better. Mm-hmm. Yes, ma'am.
My question is, it has to do with electronic records.
Mm-hmm.
Do you find that it's growing, or that people want, or that hospitals are like working together to streamline like having electronic records? Because you talked about a lot of paperwork, or is the paperwork because of maybe growing technology in terms of record keeping?
So electronic paperless systems have created more paper, but it's mandatory now to have electronic health records, and you have to get on board with that. A lot of the things that you report have to come out of electronic medical record. The other thing is patients have to be able to access their electronic health record through a patient portal within 48 hours after discharge. And so we have to have those things electronic.
Do you find that it's easier for primary care clinics, primary care physicians to thrive independently, or are you seeing more clinics having to merge with hospital systems?
Yeah, I mean mergers are huge. Mergers and acquisitions. A lot of doctors coming out of residency are looking to be employed, just because it's very difficult. It's very expensive now. It used to be you go into a practice and you just start seeing patients. Now you've got to have an EMR and you've got to have all these other things, and it's very difficult. It makes them a little bit more inefficient to see patients, and so they can't see as many, and they, so that affects their income. So a lot of people are looking to be employed or join really big groups. Yeah, sure.
So I was just curious. So I think that one area that gets overlooked quite often within a lot of rural hospital markets is the fact that rural hospitals are in a lot of cases the primary economic driver for rural communities, and when they go belly up, it's the impact trickles way beyond just not having access to care. So I was curious if you could comment or elaborate on your perception of where your hospital or your group kind of sits as an economic driver within the rural community.
Yeah, that's a great point. So the independent school district is the only employer that employs more folks than we do, but we've got a bigger salary. I mean, we pay more money per employee. And so, I mean, that would be a huge impact, huge impact, especially in some of these rural markets where other organizations are leaving, or where I'm at, the timber industry really, when it went away, it really had a big impact. So the school district and the hospital are really the big drivers for the economic activity in the area. So without the hospital, you would see a huge hit to that community, and that goes with a lot of the communities in our area.
Dr. Gray mentioned that you did some work abroad. Can you talk a little bit about what that was? Yeah.
So I went over and worked for a company that operated hospitals in Egypt and Saudi Arabia, and that was very. She said I ran hospitals. I didn't run. I tried to run hospitals. But they don't have a lot of the standards that we have here, and so the evidence-based medicine was not practiced a whole lot. Where I was at, I'm not saying international hospitals as a whole, just in my experience in Egypt and Saudi Arabia, they were private hospitals, and it was like each physician practiced totally independent, even if it was in the same specialty, and so it was very difficult. Of course, they wanted to be Joint Commission International accredited, but they didn't really want to change anything they did. One of the doctors that I was talking to in Egypt said, "We've been doing this for 6,000 years, and we're not going to change now." Okay, well that's a tough attitude to work with. But it was interesting. So a lot of the patient satisfaction stuff that I thought was kind of silly before I went over there had become really important to me now. And so treating everybody like they're a VIP, not having like a VIP floor and a Class B floor and a Class C floor. That became very important to me. The way you interact with patients and the way you treat them and help them or allow them to participate in their care was non-existent where I was at. I'm the physician. You do what I tell you to do, and you don't ask any questions, and you don't give me any flack, and go away. And so that's obviously much different than it is here, and rightfully so. Yeah, it was much different. Anything else?
So first, let's give Lance a round of applause. And we do have just doesn't look very small, but it is a small token of appreciation. And Lance will be in the student lounge here for a few moments or longer. If any of you would like to hang out, or if you have additional questions or thoughts that you'd like to share with him, you're welcome to join him in the student lounge. So thank you again so much. He is flying back to Texas this afternoon, and I hope that we see you in November for the third breakfast in this way. Thank you again.
Don't forget to turn in your breakfast with the slips of paper. Don't forget to legislation.
Yeah.
No.